Hi guys, so today we are covering the rest of chapter 18, which is blood. So we're going to basically be talking about white blood cells. So white blood cells are officially called leukocytes, and all of the body cells have surface proteins on them, even the white blood cells. And these are called major histocompatibility antigens, or MHC antigens. Now these are unique for every person except for identical twins, of course. So this is actually what we use to do tissue typing if somebody is going to donate something to someone else. They do a histocompatibility test, and basically what they want to do is match up the antigens as close as possible, because the higher the match, the less there is a chance of rejection of the organ or tissue, whatever is being donated. White blood cells come in two types, granular and agranular. As the names imply, granular have granules and they look grainy and you can actually stain them. Agranular do not have granules. So granular leukocytes are the eosinophils, basophils, and neutrophils, while the agranular leukocytes are lymphocytes and monocytes. Monocytes will differentiate into macrophages, and they can be fixed in one place or they can wander around and look for cellular debris. Very importantly, white blood cells usually live only a few days, but some of them can live months to years. A normal white blood cell count is 5,000 to 10,000 leukocytes per millimeter cubed, but the function of white blood cells is to fight infections. They do this in a variety of ways. Antibody production and phagocytosis are just two examples, and we will actually get into the details of white blood cells and how they fight infections when we talk about immunity. But in order to fight infections, white blood cells have to leave the blood. They do this through a process called emigration. So as they're moving through the blood vessel, it kind of rolls to a stop, and then it just squeezes out of the blood vessel and jumps into the tissues. Granulocytes and monocytes will never actually return to the blood. They will go to the tissues to fight the infection, and that's it, they're done. Lymphocytes, however, can go back and forth between the blood and the tissues. And again, we'll talk about all of that when we get to immunity. Leukocytosis is when you have a greater than normal count of white blood cells, and this usually indicates that you have an inflammation or an infection of some type. Leukopenia is when you have a less than normal count of white blood cells. These are the 5 types of white blood cells. Remember, never let monkeys eat bananas, and that will help you remember the order from greatest concentration to the lowest concentration. So neutrophils are the highest concentration, and they are the first responders. They're going to be the ones to get to the scene first, and then they'll assess the situation, figure out what's going on, and if they can fight it themselves, they will. Otherwise, they will call for the appropriate cell to come in. Neutrophils are best at bacterial infections, while lymphocytes are best at viral infections. Monocytes can fight viral or fungal infections. Eosinophils are really good at parasitic infections. So if you have a parasitic worm of some type, eosinophils are going to be the ones to fight that. And then basophils are allergic reactions. They actually have histamine, which they secrete. So high counts, you can look at what those indicate versus low counts and make sure you're kind of familiar with what they mean in general. All 3 types of granular white blood cells have a segmented nucleus. Eosinophils, which are the parasitic infections, but they're also involved in allergic reactions, they have red-orange granules in their cytoplasm, and the granules contain histaminase. Now you can tell from the ASE ending that that's an enzyme. So it's basically an antihistamine. They phagocytize antigen-antibody complexes, and they're involved in parasitic infections, as I said, and allergic reactions. If you have a high eosinophil count, it usually means either you have a parasitic infection or an allergic reaction. Basophils contain blue and purple granules, and they're called mast cells once they move out into the tissues. The granules contain heparin, which is a blood thinner, histamine, which we know histamine is the allergic reaction, and serotonin, which helps our mood regulation. They're involved in the inflammatory response, and if you have a high basophil count, it usually means you're having an allergic reaction. It can be related to certain leukemias, though. Neutrophils, the last type of granulocytes, have pale lilac-colored granules. These are actively phagocytic, and they use chemotaxis to call other cells to the area that are needed. So when they get to the area, as I said, they're the first ones there. They assess the situation, and then if they need a different type of cell there, they will release chemicals to call it over. After chemotaxis, the neutrophil is going to ingest bacteria, dead matter, or anything that it can, and then digestive enzymes in those neutrophilic granules will actually destroy that ingested material. Neutrophils also produce defensins, which are natural antibodies. And what they do is they take a bacterial cell and they release their defensins, and it punches holes in the bacterial cells so they can't survive. If you have a high neutrophil count, it usually means you have a bacterial infection, but it can be associated with certain leukemias as well. And there's a picture over there of the neutrophils. The agranular leukocytes are also called mononuclear leukocytes. Monocytes are extremely large cells, and the nucleus is either kidney-shaped or U-shaped. The cytoplasm is blue-gray. Now, when a monocyte leaves the blood, it matures and differentiates into a macrophage. Some of these are fixed, so they stay in one place. Others move around between tissue sites. They're actively phagocytic, just like neutrophils. They're better against fungal infections and TB. Neutrophils are better against bacterial infections. Neutrophils, as I said, reach the infection site first, but once macrophages get there, they can actually react faster. And then they'll also help clean up the mess. Lymphocytes are oval round, they have a dense nucleus, and they may be slightly indented. Their cytoplasm is blue, and as you can see from the picture, there's a very thin ring around the edge, and that's how you can tell lymphocytes from all the other cells. There's three major types: B lymphocytes, which produce antibodies, T lymphocytes, which can attack invaders, like viruses and transplanted cells and bacteria. Natural killer cells attack invaders and tumor cells, and natural killer cells are always kind of wandering around looking for foreign matter. Again, we're going to talk a lot about this when we get to the chapter on immunity. So all of the above lymphs can be involved in transfusion reactions, tissue reactions, and allergies. If you have a high lymph count, it usually means you have a viral infection, but again, it can be involved in certain leukemias. A white blood cell differential will actually tell you what percentage of each white blood cell type you have so that you can be diagnosed properly. Thrombocytes are platelets. They're actually fragments of the megakaryocyte membrane. So thrombopoietin is the hormone that signals we need to release these megakaryocytes, which will then mature into megakaryocytes. Megakaryocytes, the membrane is then going to start to fragment off, and those fragments are platelets. So each thrombocyte or platelet is the membrane plus the granules plus the cytoplasm. It's disc-shaped and it doesn't have a nucleus because it's just a fragment of the megakaryocyte membrane. They have clotting chemicals, though, very importantly. So platelets act in blood clotting. Their lifespan is about 5 to 9 days. So the function is hemostasis, so we want to stop the bleeding. The first thing that will happen when you get a cut or a tear is a vascular spasm. And that's basically the walls are vasoconstricting. So it's going to contract the circular muscle and it's going to basically stop blood loss. So this happens right after the damage. When the nociceptors detect the tissue damage, they're going to start this reflex for the blood vessel to start spasming and constricting. Now, it can last minutes to hours depending on the situation and how bad it is, but the point of it is to reduce blood loss. The next thing that's going to happen is platelet plug formation. So once the vessel tears, the vascular spasm is going to start constriction so that the blood loss will be slowed. Platelets are going to come to the area. Platelets are going to release more chemicals to get more platelets to the area, and then they become spiny and release their clotting chemicals. They start to stick to each other and get bigger and bigger and bigger until we can stop the bleeding, basically, and a platelet plug is formed. How does clot formation even happen? How does coagulation start? What happens? First of all, the liquid portion of the unclotted blood is called plasma, but the liquid portion of the clotted blood is called serum because it's already released its coagulation factors, so it doesn't have any more. The blood clot itself is made up of a fibrin mesh made by those coagulation factors in cells. There's 3 stages to it. The first thing that happens is prothrombinase is formed. As you can see, that's an enzyme and it's going to activate prothrombin. So that will activate prothrombin to convert to thrombin. Once it is converted to thrombin, that's going to activate fibrinogen, which is soluble, to convert to fibrin, which is insoluble. So now we have this fibrin mesh that came about, and it's going to be surrounding the cells, and it's going to cause the blood to clot and bleeding to stop. Coagulation factors are 11 plasma proteins plus calcium, and this all happens in a cascade. So the cascade can be initiated in one of 2 ways, either extrinsically or intrinsically. The extrinsic pathway takes very few steps and happens very fast. Basically, the protein tissue factor is going to leak into the blood and cause the cascade to occur. The intrinsic pathway is more complex and it's slower. And basically, when the endothelial cells are damaged, the nociceptors pick that up, phospholipids are released by the activated platelets, and then the cascade occurs. So it takes a little longer. The coagulation factors interact in specific sequence, and it's eventually going to convert the fibrinogen into fibrin. And then the fibrin mixes with the cells, and you have your clot. Each coagulation factor has a name and a Roman numeral. For example, coagulation factor 3 is tissue factor. This is what's released from the damaged cells. So here's a picture showing you how this all happens. So you start with a tear. The vascular spasm is going to constrict the blood vessel so that it reduces blood loss. Platelets are going to come to the area, getting more platelets and more platelets until they form a platelet plug. And then either the intrinsic or extrinsic pathway is going to be initiated. The cascade of clotting factors is going to occur. Prothrombin is going to be converted into thrombin, which will then convert fibrinogen into fibrin. And there you have your clot. Thrombosis is when a blood clot forms inside a blood vessel that hasn't been damaged. Basically, natural anticoagulants aren't being effective. Patients that have an increased risk of forming clots may receive anticoagulation drugs, or blood thinners as we call them, like heparin or warfarin. An embolus is a blood clot, air bubble, flat globule, or debris that got released into the bloodstream. The problem with these is that they can lodge into the tissues, and when they lodge into the tissues, it blocks the blood supply to wherever they're at. So if you get a pulmonary embolism in your lungs or a cerebral embolism in your brain, this is a very serious thing and can lead to death. Hemophilia is a deficiency where you are missing a clotting factor, so you will bleed a lot. If you cut yourself a little bit, you will start bleeding. My dad had hemophilia and he would bleed like crazy. Hemophilia A, you're missing a factor 8 deficiency. Hemophilia B, you're missing a factor 9 deficiency. Hemophilia C, you have a factor 11 deficiency. Now, hemophilia A is the most common, so they actually have factor 8 shots that you can get to replace what you're missing, and then you're not going to bleed as badly. Normal coagulation also requires vitamin K, because vitamin K is used to synthesize factors 2, 7, 9, and 10. So if you don't have enough vitamin K, you are not going to make these coagulation factors. Coumadin is a common anticoagulant, or blood thinner as we call it, and basically what it does is it creates a vitamin K deficiency on purpose. Clot retraction is when the clot shrinks and tightens up, and fibrinolysis is when the clot is dissolved. Our body naturally dissolves blood clots. Sometimes we will actually induce it artificially to dissolve any thromboses that have formed inside the blood vessels when they shouldn't be. So here's a chart showing you the factors, the name, the type of molecule it is, where we get it from, and the pathway that it uses to start the cascade effect. If you've ever been in a hospital, you've heard of CBC, a complete blood count. It screens for anemia and a lot of other various infections. It counts your red blood cells, your white blood cells, and your platelets. It also gives you your hematocrit, which is the percentage of red blood cells that you have, because if you have a high percentage of red blood cells, your blood is going to be very thick. If you have a low percentage, your blood will be a lot thinner. And a differential white blood cell count, which again tells you how many of each white blood cell you have. And then it can compare it to the normal count and determine if anything's high or low, and then go from there for your diagnosis. And finally, it tells you your hemoglobin, so how well oxygen is getting carried to your tissues. Blood typing is something that is very necessary for a lot of reasons. Red blood cells basically have a surface antigen. That antigen is the blood type. So if you are type A, that means you have the A antigen. Type B, you have the B antigen. Type AB, you have both antigens. And type O, you have neither antigen. Now, whatever antigen your body has, you have the antibody against the other one. So if you're type A, you have A antigen, that means you have antibody B. Type B antigen, antibody A. If you are type AB, you don't have any antibodies, but if you're type O, you have both antibodies. Well, why is that important? It's important because the antigens determine your blood type, and the antibodies will fight against whatever antigen you do not have. For example, if you are type A, you have the A antigen and antibody B. So if you get a transfusion of blood of B, your body is actually going to attack it and clump it together and agglutinate it, which is obviously not a good thing. The universal donor is known as group O, and the universal recipient is known as group AB. The reason is O does not have any antigens to elicit a response. So everybody can get O because there aren't any antigens to have the antibody come after. AB is universal recipient because they don't have any antibodies to go against anything. So no matter what antigen comes into play, they don't have any antibodies. So O can donate to everybody, AB can receive from everybody. However, these generalizations can be a little misleading because we have a lot of other blood group systems to consider, like Lewis and Duffy, for example. Here's a chart just summarizing the ABO blood types and including the Rh factor, which we're going to talk about in a second. This is a summary of the blood types, the antibody you have, the antigen you have, and what you're compatible with, which we'll talk about that in a second as well. So Rh is another factor that's on our red blood cells. Either you have the Rh antigen or you don't. If you have the Rh antigen, you're Rh positive. If you don't have the Rh antigen, you're Rh negative. So that's where the plus or the minus comes on your blood type. So if you're B positive or A negative, it's talking about the Rh factor. Now the problem with this, we're going to talk about hemolytic disease of the newborn right now. If you have a mother that is Rh negative and a baby that is Rh positive, what happens is everything is fine on the first child. But when the child is born and that placenta detaches, the blood mixes temporarily. So the mother is now exposed to those positive antigens. So what will happen is between pregnancies, basically, the mother is going to make antibodies against Rh factor. So if you get pregnant with the second child that is Rh positive, your antibodies are going to go after the child because you have antibodies against Rh factor. Luckily, there is a shot now called Rogam that is administered to an Rh negative mother within 72 hours after delivering an Rh positive baby. And basically what's going to happen is that's going to prevent her from making the antibodies so the baby will be safe. If something does happen and the baby ends up with hemolytic disease of the newborn, it can cause hemolysis of the baby's red blood cells, so they will burst, jaundice, developmental delays, and potentially death. So as I said, blood typing is used for a variety of purposes. We need to know it for blood transfusions, paternity cases, linking suspects to crime, and even anthropology studies. Like I said earlier, in a blood transfusion, if you receive the wrong blood type, your antigen antibody reaction is going to occur. You're going to have agglutination, which is clumping, and then hemolysis, which the red blood cells are going to burst. So the wrong blood type can cause the patient to develop fever or go into renal failure and shock. So it really depends on the amount of blood that they received. Some disorders are homeostatic imbalances. Anemia is when you do not have oxygen carrying ability on your blood. It is reduced. So you either have a decreased red blood cell count or a hemoglobin deficiency, because hemoglobin is what carries the oxygen, remember. There are different types of anemia: iron deficiency, pernicious, hemorrhagic, hemolytic, thalassemia, aplastic. So make sure you're familiar with the different types of anemia as well. Sickle cell disease is when you inherit an abnormal type of hemoglobin. Now, hemoglobin is a chain of 287 amino acids. One substitution for the wrong amino acid causes sickle cell. You can see in the picture those cells are sickle-shaped compared to the normal cells. So what will happen is when they're traveling through the blood vessels, they're going to get stuck. And when they get stuck, now you're blocking blood flow to that area. It can be a minor pain and discomfort all the way till death, depending on how many cells you have that are actually sickle-shaped. Hemophilia, we already talked a little bit about, is that bleeding disorder. It's an inherited deficiency of, you're missing clotting factors, basically. Acute leukemia is a malignant disease, and basically what happens is your leukocytes are produced uncontrollably. Chronic leukemia is an accumulation of those leukocytes in the bloodstream. So acute is when you just have an uncontrolled accumulation for some reason. It's still bad, but chronic means that they have accumulated in your bloodstream now. Thrombocytopenia, you have a decreased level of platelets, so you're going to have a decreased clotting ability. Pancytopenia, you have a decrease of all your blood cells. So obviously that's going to cause a lot of problems, and with immunity as well. So make sure you read these parts in your book so that you can be familiar with the basics of these. We've talked about a lot of these, and you don't have to know every single detail about them, but just make sure you're familiar with them. So that's it for now. So as always, if you have any questions, just ask. Otherwise, I will see you for chapter 19. Bye.